Hello, welcome to this NMC OSCE tutoring video. My name is Hannah. I am an experienced UK registered nurse of 20 years and a university lecturer of nearly 7 years. And I've been an NMC OSCE programme lead. And I run my own nursing tutoring business where I can support you with your OSCE preparation and give you some one-to-one tutoring sessions and advice and support as well. So I am sharing with you my top tips and study information to help you prepare for your NMC OSCE exam at home. It's a really difficult exam and can be really expensive to go to training centres as well. So I'm hoping this information helps you. Please like and subscribe, and also share my videos in any OSCE forum groups that you're on or with friends and family also studying. So today I'm going to look at the Glasgow Coma Scale assessment. I've had a request for this. And my first bit of advice for the Glasgow Coma Scale is to go to the NMC Test of Competence webpage and to their supporting documents, and make sure you are using the Glasgow Coma Score Observation Chart, which is in their supporting documents pack, okay, because this has been updated. And there's a lot of older versions of the GCS chart which are on the internet and in different training resources. So if you're an adult nurse, you need this version here to be practicing from, okay? And the main difference with it is the respirations and the oxygen saturations appear under the blood pressure and pulse rate here. So it is quite important to be working off the most up-to-date version of that Glasgow Coma Scale. And also some of the terminology has been changed. So instead of to pain, we say to pressure. So just it's important to be up to date with your practice anyway, but especially for the exam. Okay, let's start then. So the Glasgow Coma Scale, so you most probably familiar with this from your practice as nurses in your home country, and it is a scale used to assess the person's level of consciousness. And I was a neurosurgical and critical care nurse for 16, 17 years, so a tool that we used lots and lots in our patients in terms of assessing their GCS. And it assesses 3 areas of consciousness, so looking at eye opening, verbal response and motor response. And you can go to the Glasgow Coma Scale website. I've put a link in there, and do a bit more background reading about this. And also it's got all the up-to-date terminology that I was talking about. And the GCS scale will only come in your NMC OSCE if you get the subdural hematoma API. So it only forms that scenario. In your child OSCE, it is part of the PEWS early warning score as well. So you'll see that on the PEWS chart. So just be familiar with that and your child technique for GCS. And you will have your Glasgow Coma Scale assessment chart, which includes where you also document your observations, and you will not have a News 2 chart if you have the subdural hematoma. So you will be putting all your documentation, your observations, your vital signs, and your GCS assessment onto the one GCS documentation chart, which I just showed you at the beginning. So if you have the subdural hematoma API, which includes the GCS, you still need to complete your full assessment station. So you still need to do exactly the same as you do in your other APIs. So your key principles, you still need to complete your A2 assessment, and you still need to do your holistic assessment. So all the same marking criteria applies. So where do you do your GCS in terms of that assessment station? So it's important that you still complete your A2 assessment, and you do that in the correct order, and you do that systematically. So you're still going to start with airway. You make sure the airway is clear, no signs of visual obstruction. You are then going to move on and do all your breathing, so respiratory rate, rhythm, depth, respiratory noises, signs of respiratory distress, unequal airway, unequal air entry or equal air entry, and oxygen saturations. Then you're going to do your circulation exactly the same as your other assessment stations, so pulse, rate, rhythm, depth, halo and perfusion, blood pressure, and capillary refill time. And then when you get to disability, instead of doing that ACFU-POO, you are going to replace that by doing your full GCS assessment instead. And that is keeping within your systematic order. And that's where you should be doing your GCS assessment. So instead of doing ACFU-POO, you're going to do a more in-depth assessment. Now, you do need to give yourself a bit more time because obviously the GCS assessment is going to take longer to complete than doing your ACVU-POO. So you need to be good on your time and be able to get through the rest of your A2B assessment relatively quickly in order to have some extra time to do your GCS assessment. And you still need to do the rest of the disabilities. Once you've completed your GCS, don't forget to do the urine output, the patient's pain, and ask for the blood glucose. And you still need to complete all of exposure, so the temperature, the top to toe assessment of bleeds, bruises, rashes, wounds, and your full medical history. So that's where I would put the GCS assessment in. It will help you keep that nice order, and it will also demonstrate that you're still using that A2E approach. So completing the GCS, so you'll know that it's made out of 3 components. Eye-opening is the first one, so eye-opening spontaneously, eye-opening to sound. So this is new terminology. You might have heard it as eye-opening to voice, but it's now to sound, to pressure instead of pain, and no response. Now, your patient actor is most probably going to be awake with their eyes open, and so you would just need to verbalise, I can see that you've got your eyes open and you're opening them spontaneously. And you would mark that with a dot on your GCS chart. So on your GCS chart, make sure your patient details are filled in, the date, which will be the date of your test centre, date of birth, and make sure you put the time, so the time of your station, and like with our news 2 charts, just a dot in the chart. If your patient actor is lying with their eyes shut, then you just ask them their name and ask them to open their eyes, in which case you'd document them as a 3 to sound. It's very unlikely your patient's going to be responsive to pain. You're not going to be inflicting pain onto your patient actors in the test, and they will always have some level of response for you. So you can practice with them being spontaneous or potentially eye-opening to sound. Then you're going to go on to your verbal response. So with the verbal response, we need to assess if they are orientated, and we look for them to be orientated to time, place, and person. So you need to ask them 3 questions which assess those 3 components. So first is, are they orientated to themselves, their person? So ask them to repeat their name again. Do they know where they are? So place, so ask them where they are. And then time, do they know what the date is? If they get those all 3 correct, then they are orientated, and you would plot them as a 5. If they get any one of those wrong, or all of them wrong, then they are confused, and you document them as a 4. Now, very often in the subdural hematoma, the patient actor is confused, so they come out as a 4, but also make sure you do your thorough assessment and don't assume anything. So asking your patient if they're orientated to time, place, and person, exactly the same as we did with the ACVU-POO when we were trying to assess if they had confusion or not. It's really important, if your patient actor is showing confusion, that you take a little bit of time just to reorientate them and reassure them. So I may say, for example, to my subdural hematoma patient, Margaret, it's okay, you are in hospital and you're perfectly safe because you've had a fall, and we are doing some investigations to identify if you've got any injuries, for example. You're nice and safe, or I've called your family. So just reorientate them back to the place and time and explain to them what's happened. And that's really important, always thinking about that patient-centered approach and not just trying to get through the marking criteria like a robot. Again, your patient is most probably always going to be either oriented or confused in terms of your OSCE. If they are just saying single words, then you would document them down as a 2. They weren't verbalising to you at all, which is very unlikely because you've got to complete your holistic assessment as well. They would be a 1. And then onto your motor response. So you want to see if your patient is obeying commands. Motor response, most important part of the GCS, tells us what's really going on in terms of motor function and the brain. So just ask your patient to do something really clear, which you can identify that they're obeying commands. So you could ask them to stick their thumb up or stick their tongue out, in which case they're obeying commands. You shouldn't have to. Your patient actor should do that for you in your OSCE. You shouldn't have to be applying pressure or pain or painful stimulus in your OSCE, which is how we assess for localizing or flexion or abnormal flexion. So in terms of your OSCE, you don't need to do that. But in terms of your ongoing practice, then we, as nurses, if we do need to apply some pressure or painful stimulus, we'd normally squeeze the trapezium muscle at the back here. as our first point of call. And if someone is localizing, we want them to bring their arm up across the nipple level and across mid clavicle level up to that level of where you're delivering the pain. You can give supraorbital pressure here in the ridge just above the eye. You just need to be careful around things such as facial fractures or surgery. So normally always go for the trapezium squeeze first. We don't do sternal rub or anything like that any longer. So in terms of your OSCE, patients should be obeying commands, but again, make sure you assess that and demonstrate that knowledge. And I'd mark that with a dot in my 6 there. Once you've done your eye response, verbal response, motor response, you need to do the rest of your assessment and documentation on your GCS chart. So you must also assess the pupils and you must assess the limb strength. And I do this before you move on to the rest of disability. So before you move on to your pain, urine, blood glucose, and before you move on to exposure. So get that GCS all done and complete. Stay in that really nice systematic order. So pupils, you'll have a pen torch, you're going to assess the pupils for their size, their shape and reaction to light. So again, explain to the patient, you're going to shine a bright light into their eyes, bring the light in from the side, and you're looking for that pupil to constrict when you bring the light in, and obviously dilate back out when the light goes. And again, repeat to the other side. As with everything in your OSCE, verbalise the size, the shape and reaction to light. And there's a sizing chart on the side of the GCS chart. And so you just kind of decide what size they were, so maybe 3 millimeters, 4 millimeters. And if they're reacting to light, you'd put a plus in the box. And if they were fixed and not reacting to light, it would be a minus. But most of the time it's the pupils are reacting to light, unless they've got a false or glass eye in, potentially for your patient actor. So again, document that down. So the size goes in here as a 3 for my right pupil, and reaction was a plus, and again the left reaction is a plus. So be really careful with your documentation. And then you're moving on to assess limb strength. And this is a really, it's very simple in terms of your NMC OSCE. You haven't got time to do a very in-depth assessment of limb power and limb strength. So just demonstrate a very simple technique here. So assess the power in the arms and the legs. So you can ask the patient to squeeze both your hands and let go and see if one is stronger than the other. You can ask your patient to pull you towards you and push you away, okay, and assess if there's any difference in those arms. And the legs, again, you can get them to lift their leg up against your hand and push it back down again, and push their foot down against their hand, and again assessing if there's any difference. If when you assess the limbs, you feel there is equal and normal power in both sides, you can mark that as a single dot because they're both the same. So my normal power in my arms and my legs, and I put that both sides. If when you're assessing, actually the left one is weaker than the right one, then you need to differentiate that out into your chart. So I would put the right here. So I'd put the right as normal power, and then an L for left, indicating that that left side had a weakness. And if that was the same in the legs, I'd put a right and a left. So make sure you're clear on that. Sometimes that can cause a bit of confusion. So if it's equal power both sides, you can just put a dot. Or if it's equal mild weakness, you can put a single dot in the box. But if there is a difference between one side or the other, then you need to separate that out with an R and an L, indicating which one is which. Once you've done your GCS and plotted the rest of your observations, you need to verbalise the GCS score. So that's the total of your eye, verbal and motor response. So like I said, most of the time patients confused and have a GCS of 14, but not always. So just make sure you do your assessment thoroughly. But my eye response was 4, my verbal response was 4, and my motor response was 6. So that gives me a total score of 14. So right at the bottom of your GCS chart, you'll have the total GCS score, and you need to write the 14 in there, and you need to initial it as well. And similarly to your News 2 chart, you have to escalate your frequency of monitoring on the basis of that GCS chart. Now, you don't get any additional documentation to support you with this, so it's not like in the News 2 where you have the escalation policy with you. You need to learn and you need to know this, okay? So if your patient has a GCS of 15, but they've had a history of head injury, so like in your subdural hematoma, you should do your observations half hourly for 2 hours, 1 hourly for 4 hours, and then 2 hourly. And that's following NICE best guidance practice for management of head injured patients. If your GCS is 14 or less, which is very common in your assessment station in your OSCE, then you need to verbalise that you are going to monitor them half hourly until the GCS reaches a score of 15. So those two bits are really important to learn, because you won't have that on a sheet to help you like you do in the News with your escalation. Okay, so you need to add up your score and verbalise your monitoring frequency based on the GCS. Otherwise, it will be a critical fail. And then you also need to go and document the rest of your vital signs on that same GCS chart. You won't have a News 2 chart. So again, make sure you've got the most up-to-date version, like I showed you at the beginning. So starting again with your respiratory rate and your saturations, they get written in the box. So you put the number of your respiratory rate in and the number of your saturations. So there's no scale for you to plot on the chart. So you need to write the actual number in. So make sure they are correct with what you've verbalised and measured. Your blood pressure and pulse, you document exactly the same as you do on your News 2 chart, but they share the same scale. So on your News 2 chart, you've got a separate scale for blood pressure and a separate section for pulse, but they share the same scale. So you need to make sure both are really clear. So make sure if your pulse falls within your blood pressure parameters. So here I've documented a blood pressure of 105/70, and my pulse is 75. So I've just moved my blood pressure slightly over so I can dot that pulse separately. Don't mark your pulse on top of the blood pressure line, if that makes sense. Be careful of the scale here, because it's slightly different than your News 2 score. Okay, so the very bottom line here at the bottom is 0, and then this is 20, 25, 30, 35, 40, 45, 50, 55, 60, 65, 70, 75, my heart rate. 75, my heart rate goes there. So just again, I'd print off a copy of this and familiarise yourself with it and practice documenting some observations down. You also need to document your temperature, and you can again put a dot or some, so you can put a cross in. It doesn't massively make a huge difference. And again, just put the temperature in. Now the temperature comes at the top of the chart under the GCS, and it's your blood pressure, pulse, then it is your respiratory rate, saturations, and then it's your pupils, your limb strength. But still make sure that you're still doing that correct systematic order. So your temperature should still be your last vital sign that you take. So my top tips is, remember, you still need to complete all the assessment station criteria and fulfill the assessment station marking criteria. You still need to do your full A2 assessment. When you get to disability, instead of doing your ACLU-POO, do your complete GCS. This will include your eye, verbal and motor response, your pupils, so reaction to light, size and shape, and your limb strength. Don't forget to reassure me or take your patient if they are confused. That is really important, showing that patient-centred approach. Document your GCS and observations correctly on the GCS chart and take your time. Okay, add up the GCS score and document that at the bottom with your initials, and verbalise your score and your monitoring frequency. So remember, if they're 14, we monitor the GCS every 30 minutes until their GCS is 15. You still need to complete a holistic assessment, so you need to manage your time really effectively in the station, because your GCS will take a little bit longer to do, but you still have to complete all the same requirements. I hope you found that helpful, especially to the people that have requested that. I am available for tutoring and support, and you can either book in for a whole series of sessions where you can go through all the OSCE, or you can just book 1 or 2 one-off sessions. I did a session this week with a nurse who's done all her study at home and then just wanted to ask me some questions and run through some stations and clarify things. So can do that, can be flexible with timings as well, and whenever I can, I'll try and work around your budgets if I can. Or you can just contact me and get access to resources. So I've got API scenarios, professional values, evidence-based scenarios, and some study support resources as well. You can feel free to email me, hannah@outlook.com, or visit my social pages, Nurse Tutor, Tutoring with Hannah on Facebook and Instagram.